Yeah, hello everybody. So this is the results of new intervention trials in people at clinical high risk of psychosis symposium. And we have 4 very exciting presentations. And also a discussion at the end. So Alison Jung is giving some discussion points at the end. Yeah, so we start off with Helen Stein. She will be professor of psychology at Leeds Trinity University in 1 week's time, as I just heard. And she will present on a randomized control trial of cognitive behavior therapy versus non-directive reflective listening for young people at risk of developing psychosis. Thank you for coming.
Thank you, Andreas, and thank you for organising the symposium. And thanks to people for coming along to this session when I know the sun is shining beautifully outside. Okay, so I'm going to present the findings of a randomised controlled trial that we conducted in Australia in both an urban and a rural site. Okay. And there we go. Okay, so just briefly then, because I'm sure you're all familiar with the ultra-high risk or at-risk mental state criteria. For our study, we focused on the CALMS criteria developed by Alison Jung and colleagues. So looking at low intensity or frequency of psychotic symptoms, or brief limited psychotic episodes, and or genetic risk, all of those in the presence of a functional decline. We know from a meta-analysis, in fact there have been several now, and we've just missed one. Okay, if we look at the randomised control trials for the ultra-high risk group, there have been studies that have looked at medication effects, the omega-3 studies, and some psychological intervention studies. So one meta-analysis reported in 2013, out of 11 identified RCTs, found 7 that had involved CBT. And they found a positive effect for CBT in preventing transition to psychosis for that group at 12 months. Oh, there's a total problem. It's a problem with my fingernails, sorry. So the meta-analysis that focused just on CBT trials showed the relative risk for developing psychosis for those receiving CBT was reduced by at least 50% at 6, 12, 18 and 24 months, and that the number needed to treat for one person to avoid transition to psychosis at 12 to 24 months was around 8 to 11. So CBT was associated with reduced sub-threshold symptoms at 12 months, but these studies were not showing an effect on overall functioning or symptom-related distress. Oh. Okay. Sorry. I'll get it right in a minute. Really. Okay, so the DEPTH trial then is a single-blind randomised controlled trial where we compared CBT with an active control condition. Now this is important because that's quite different to the other trials that have been conducted. Our active control was non-directive reflective listening. Our sample was 14 to 30-year-old young people meeting the CALMS at-risk criteria. As I said, was conducted in 2 sites, one a rural setting and one an urban setting. Treatment began within 2 weeks of completion of baseline and was offered for a 6-month period up to 26 sessions. And I think, no, we're right. Getting the hang of it. So randomisation was stratified by sites to control for site-specific differences, the urban-rural, and by receipt of antidepressants.
Sorry.
Why is it so hard? My fingernails, isn't it? See?
Okay.
Now we're back.
Yeah.
No, I need to go forward. That's it. Okay. So just briefly then, non-directive reflecting listening is a form of person-centred counselling where the therapist offers empathic reflections while adopting a stance of genuineness. Participants were invited to talk about any topic of their choice. More assistance. Any topic of their choice, and they were allowed to guide the content of the sessions. Now, as therapists, we thought that would be quite difficult to start with because although we do get some young people who like to talk a lot, there's also a lot of young people, particularly the young boys, who, you know, are really don't say much at all. But it actually was quite well received by the young people. And we monitored to make sure that there were no CBT techniques used in that. Both groups received standard care, which was primarily just case management. We, as I said, monitored for treatment fidelity, importantly to make sure that there wasn't contamination across both treatments because the same therapist offered CBT and also the active control condition. So as you can see there from the slide, there's benefits and risks of having that happen. But through our fidelity measures, we were able to check and from the results show that there was not that cross-contamination. Our outcome was, the primary outcome was transition to psychosis, but we're looking at secondary outcomes as well. We really wanted to focus on functioning outcomes. Oh, I feel like I'm learning to use a video game. So just looking at the flow chart then, as you can see, there's quite a few people. I was quite interested to see David Fowler's presentation this morning when he had these thousands of people who, you know, were referred at the start, right in that top box in the flow chart, and then it kind of peters down. Well, that's what we experienced as well. So although we had 564 referred, by the time we got to completing the assessment to check people met criteria for the study and had them consent and be available, particularly for our rural young people who tended to be moving around in and out of the area a bit, we had 57 people allocated to treatment. So that was 27 to the active control and 30 to the CBT group. And it's important to note here too that there's quite a bit of attrition when you look at the follow-up figures. We've got something like 53% attrition by the time we get to the 12-month follow-up. And some of that was to do with, as I said, young people moving out of area, but it's also about young people wanting to move on from that stage of their life. If they're actually feeling better, they don't want to be hanging around the mental health services. Just briefly, these are our assessment measures, and when we had the young people complete them, as you'll see, there's a number of functioning measures, but also substance use as well. Our analysis was primarily by intention to treat, and from there we also used the bootstrapping technique because of substantial missing data, given the multiple assessment points that we had. So looking at the results then, if we look at the demographics between the two groups, there were no significant differences on any of the demographic variables between the two treatment groups. It's important to see there that we actually had quite a young sample, so the average age was around 16 years. And if we look at the changes across time for the groups, let's see if I can look at these. If we look at the important ones here are the CALM scores, And you will see across all three of those calm scores that both groups show improvement over time. And again, when we look down at functioning, there's slight improvement, not a large amount of improvement. But then in terms of treatment effect, in actual fact, the only significant treatment effect we got was for the one highlighted in blue there, which was the distress scores, or the distress that's associated with the psychotic symptoms on calms. And that treatment effect was actually in favour of the active control condition, not the CBT. So what we did find, as I said, that in both groups there was improvement on all of those calm scores over time. There was no significant treatment effect on any of the other clinical measures like anxiety and depression, or on any of the functioning measures. We had a 5% transition rate, and that was 3 participants in the CBT group that transitioned, 1 at baseline, 1 at 2 months and 5 months. And I know Mark and I have had discussions as to whether the person at baseline should really have been included, given they transitioned so early. It's certainly a lower transition rate than other trials, and my suggestion is that perhaps part of that is because it's a younger age group, and when we look at it, they're actually better functioning than some of the other samples that have been included in trials. Okay, so in particular, I mean, when we look at some of the other trials, I'm trying to make comparisons in the literature. Some trials have very specific criteria about the level of functioning young people must have to be included. And, you know, for a number of studies, that's been a SOFAS rating of 50 or below, whereas our group had an average of around 53. And what about treatment and attrition? Well, there was no difference in the amount of sessions on average that young people had, whether they were in the CBT or the active control group. They completed 12 or more treatment sessions. There's probably on average around 9 in the CBT. Now, we might argue then perhaps there was an insufficient dosage of CBT for this sample, given the UK NICE guidelines recommend 26 sessions for first episode of CBT. We note that the UHR status had resolved for many of the participants by follow-up, regardless of which group they were in, although there were more in the CBT that had more CBT group that still met UHR status. But also, as I said, there was high attrition throughout there. So did we really have the power to find significant findings in groups? We definitely, just change that. We were unable to recruit the sample size that we wanted. In fact, we recruited 25% less young people than we needed. So, you know, we've been hypothesising about, you know, what might have led to these results, and I certainly welcome people's input in that. So is it about a natural recovery process that was going to occur? Perhaps for some of them. Perhaps our active control condition is actually quite active. Or as I said, is it an insufficient dosage of CBT? And that has been found in other studies, particularly Addington's study. So we have strengths and limitations. I think it is a strong design because of the active control. Assessors were blinded to treatment allocation. The limitations is, I think, that it was underpowered by the lower recruitment rates and high attrition. So in conclusion then, I think, you know, a significant treatment effect, at least for the active control condition, suggests that we may like to consider having a more, I guess, lower level intervention in the early stages for young people, particularly when you're looking at this age group, 16 and under, given that most of the treatment trials have been recruiting people 18 and over, do we need a slightly different approach for the younger people? And I think, listening to the talks about the various service models here at the conference, that's certainly the approach that a lot of services are using, where they're coming in with very active engagement and support in the early stages. But also what we were finding with our young people, there was a lot of other issues they wanted to talk about in therapy besides the psychotic symptoms. In fact, they were happy to put them aside for a while and work on what's happening with relationships and how come I think something's wrong with me, what's going on. So that's all I have to say. You'll be glad I'm not pressing this button anymore. And I just want to acknowledge our funders, the NHMRC in Australia, the health services that were involved in recruitment for this study. I thank them for their referrals, and the staff who worked on it. Thank you.
Yeah, we may have time for 1 or 2 questions. Yes?
Have you got an impression about how much non-directive reflective listening happened in the controls of the previous studies? Sorry, during discussions. So yeah, my question is how much of your active control was actually in the controls of previous studies? Because it sounds like something that you would do that was probably incorporated in that.
There, I've got no idea. It's certainly not something that's reported. I mean, certainly something that we wanted to go back through, and I'm not sure if we'll be able to, is to actually look at the therapy tapes, because they were all recorded, and look in more detail at the content within the sessions. I know Jean Addington's done that in hers and was then able to say that actually it was not so much the psychotic symptoms that CBT focused on, but engagement and strategy. Yeah.
So I'm just wondering if I understood your data and some of your slides. I couldn't read, but
Oh, sorry.
It looked like you had a enrollment of about 500, but at the end of the day, randomized about 50. So you had almost a 90% enrollment to randomization failure.
No, not enrolment. That's initial referral. So a lot of those people would not meet criteria.
So how many met criteria compared to the 57 or whoever were enrolled?
I think it was just over 100. I think it might have been 160, perhaps.
Okay.
But I can look at that for you later.
No, I was just curious how generalizable you think that would be.
Yeah. Yeah. You can get more details from this because we have just recently published in Schizophrenia Research.
Okay, we better move on. Thank you very much. So the next speaker is Mark van der Gaag. He is professor of clinical psychology at the Parnassian, I can't pronounce it correctly, I think. You have to say it yourself. And then much easier, academic medical center in Amsterdam. And he will actually present very exciting data because it's really long-time follow-up data, 4-year data of the EDDI trial in the Netherlands. So looking forward to that. Thank you.
Thank you very much. Yes, this is about the 4-year follow-up of the Dutch EDDI trial. First, I'll tell you 2 slides on the psychological model we used. It's not generic CBT. The main focus was to prevent the delusional interpretation on odd experiences and perceptual aberrances, because that's what's puzzling these people. And as we know from, for example, voice hearers, there's a lot of voice hearers that never develop psychiatric disorders, and they have quite benevolent interpretations on their voices. So we took the stance to prevent delusional formation. We gave also a lot of education on dopamine sensitization, and if you have a sensitized dopamine system, what this means for your perceptual and reasoning processes. And we did CBT in exploring what's going on. These people are still very open for alternative explanations. They have not been deluded yet. Then you have one explanation. And our form of CBT was very behavioral in the way that we did a lot of behavioral experiments. For instance, a young woman who thought that her thoughts were broadcasted. She had the instruction to send out most horrible thoughts during a complete week to see how the environment would react. And very often, such a one-week intervention was enough to come to the conviction that the voices were not heard by other people. Or for others, those who are afraid for ghosts, jinns, those are ghosts in the Islamic religion, and they hide in wet spaces like toilets or showers. And a lot of these people are afraid to go to the toilet at night because they might be grabbed by a jinn, and that will result into craziness. And they had to do nightly exposure to sitting on a loo for at least 15 minutes with no lights. And if they came out without insanity, this might change their ideas about jinns in the bathroom. And further, we tried to manage external risk factors and behavioral control. And these risk factors is that we told them not to use cannabis. Most people agree if I use one cannabis, I feel quiet, but if I use two, I get paranoid. And then we said, yes, that's your personal danger for cannabis. Your classmates can smoke unlimited cannabis, and they just become dull, but you might become psychotic. And that simple information was in most patients enough to stop using cannabis. We insisted that they wouldn't leave school or wouldn't leave the jobs they were in, and we encouraged them to keep on discussing these weird experiences with their beloved ones and their friends. So it was quite specific. It's all in a nice book. I can encourage you to buy it. It's not only describing the protocol, but also with a lot of examples, case examples. We screened about 5,700 people. 100 were already psychotic. That's also a gain, that you find psychotic people that have not been found before. We found 300 eligible ultra-high-risk patients, and 200 entered the study. And the 18-month results were quite encouraging. People always had also an active control condition. If people came in with panic disorder, they were anyway treated for panic disorder. And if they were randomized to the experimental condition, they had treatment for panic disorder, plus the CBT I was just talking about, directed at prevention of delusion formation. We found 10 against 22 transitions in favor of CBT, and that improves the prognosis a lot. If you can see here, if you find psychotic-like experiences in the population, 84% will remit within 2 years, 8% will stay persistent, and 8% will develop psychosis. If it's help-seeking people, it's about 50% against 2 times 25%. We also see this reflected in our control condition. About half will come to remission of subclinical psychotic symptoms, a quarter persistent and a quarter psychosis. But in the active treatment, both go down. And this is a significant difference. More people after 18 months were in remission of subclinical symptoms. And this is also a significant difference. We had less transitions to psychosis at 18 months. So we decided to, and that's much better than, being a first episode or entering stage 3, where only 40% will reach functional recovery. We decided to do a 4-year follow-up, and as you can see, we lost quite some people. We had about 56 patients we found after 4 years. So that's a loss of 44%. That's a lot. But we looked at them, and we found that the people that we lost during follow-up were doing better at baseline. They had less dysfunctional beliefs about illness, less emotional disturbance, less general psychopathology, and they scored much higher on quality of life. So we didn't lose people that made transitions, but we lost the people that at the start were not that much at risk. And that's what most of them told us at the telephone, that they were doing fine and that they closed the book of psychiatry and were not interested to do a quite extensive interview with us. So the results are probably an underestimation of the effects than an overestimation. We were quite surprised to find a 4-year effect of a therapy that was only, on average, 10 sessions add-on to the other treatment. Even with a conservative way of dealing with missing values, it's still effective. If you made a transition in the CBT condition, it was just it needed a longer duration to make the transition, which is also favorable. Months in hospital, it's a threefold difference, but not significant because it's small numbers. But if you look at the remission status, it's still measurable after 4 years. People that had the CBT were more often in remission of subclinical symptoms than the control condition. So these were surprisingly good results, and we had them reanalyzed by several other people because we didn't trust them in advance. So, but they all confirmed that our calculations were correct. Wrong button. Those people that made the transition, we looked at them separately at the 4-year follow-up, and they still had more positive symptoms, more cognitive problems, more negative symptoms. So these were not, as Jim van Os thought, that, well, you're psychotic for a couple of weeks and then you go back to normal. No, the patients that made the transition definitely still had problems after 4 years. So this is supportive of this staging model, that conditions can go up and down, but if you pass the border to a first episode psychosis, it means that you have a long-term negative outcome. These are the cost effectiveness and the cost utility analysis, and both find that there's a saving of costs, and that was quite high. If you look at the American dollars, to prevent one psychosis saved $43,000, and that's only for the health insurance. If you look at the societal cost with that, so having less disability pensions and more taxpayers, it goes up to about $95,000 for each prevented psychosis. So it's cheaper than doing nothing at all. We find the same with but lower figures at the cost utility analysis. In the cost utility analysis, you look at quality adjusted life years. That's a measure varying from 0 to 1. 0 means that you're dead, and 1 that you have perfect health. You can add them, and saving 1 year of perfect health saved about 23,000 American dollars. Jordan Lockable, he's a mathematical economist. He calculated the data from the Eddy trials and the first episode trials in Amsterdam. And if you look at the population of 17 million Dutch people, come on, it would save 10 million euros each year on mental health expenditures. It would mean that each year there would be 450 less first episode patients in the Netherlands, And if you calculate that on the long run, that will mean that you have a 15% reduction in the prevalence of psychotic disorder in the population. So that would be unique because psychiatry never found reductions of disorders on an epidemiological level. So we must see if this really will happen. But it's quite encouraging that we might reduce the number of psychotic patients in future. The recent developments is that is now part of the Dutch guidelines. So that will mean that almost all these psychiatric or mental health institutions will implement the screening and treatment of these patients. But we're also moving to a more broad prognostic modeling in prevention. Because the ultra-high risk is not only risk for psychosis, but it's a kind of risk for misery. And if you look at the developing undifferentiated psychology, it's quite unknown until the last moment. And Pat McGorry has been telling this and Alison Young for many years, but it's getting clearer and clearer that it might end up in all kinds of psychiatric disorders. Our study, has a beginning for chopping off the psychotic head from this dragon. But now we have to continue to find measures to chop off the post-traumatic stress, anxiety, addiction, and depression of this dragon to really kill it. My conclusions, this early detection is quite feasible in routine mental health care. It doesn't cost much, it saves money. This kind of prognostic modeling is successful, but it needs further improvement. And the nice thing is that these interventions are quite benign. They are very well tolerated by the patients. They're cheap, and they're much more effective than the interventions that we have available in first episode psychosis. So also from an economic point of view, mental health might become much more sustainable in future because of huge cost savings. These are all the people that are to be acknowledged. The photographs are the PhD students. Already 3 of them have got their philosopher's degree, and Helga Ising will have her degree in February next year. Thank you for your attention.
Yeah. So no psychosis anymore in the Netherlands. Yeah, questions?
Why not?
Okay, yeah, you will take away all my work, Mark, but thank you for your great presentation. Arjen Sutherland from Amsterdam. I had 2 questions. The first question is, after 4 years, what was the overall transition rate? It wasn't quite clear to me.
No.
And the second question is, we know that people who don't transition still have bad functioning. Is there any indication that your CBT also improved functioning?
Yeah, thank you. Good question. I had to skip some slides. But we only found 2 extra transitions between the 18-month and the 48-month, and both were in the CBT condition. So it was 10 against 22 at 18 months, and it became 12 against 22 at 48 months. We've done very careful screening if we didn't miss any psychotic patients. So we have been into registers if we couldn't reach the patient, if we couldn't find some psychotic patients that didn't show up, but we couldn't find anyone. So it's a quick flattening down. The Australians find transitions until 10 years, and here it seems to be almost flat after 4 years. But of course, this was a quite high-risk population. They were at the edge of becoming psychotic, and most transitions were in the first 6 to 12 months. And
How is their functioning
Yeah, functioning. It moved up from about an average of 50 on the sofas to 60 on the sofas. So that's another reason to chop off more heads of this dragon, because 20% were still clinically depressed, 20% had still an anxiety disorder, and functioning was about 60, which is not very bad, but it's also not successful living. Now, yeah.
Okay, so we move on.
Okay, I want to introduce my co-chair, even though he's already been introduced, Professor Andreas Beckdolf, who is, I will pronounce where you come from. It's Vivantes Hospital, the Charity University of Medicine in Berlin. But I think this work was also done mainly in Cologne, wasn't it, Andreas? So when he was based there before. So it's a very interesting study, and we look forward to hearing the results.
Yeah, very well pronounced. Thank you very much. Yeah, so I will present the results of this trial, although we are still analyzing it, so it's a bit preliminary still. So we were looking at CBT versus aripiprazole and clinical management versus placebo and clinical management. So we came from a bit different angle, probably in most countries you are located. It's a big issue that actually people at risk get treated with antipsychotics, right? So if you are in the field, or if there are private practices and so on, people regularly get antipsychotics. So our idea was to show that CBT is not inferior to treatment with antipsychotics. So that was the idea behind that trial. Oh, it's also not going. Okay, so there are several meta-analyses around, so Marx, and this is also one. So we know that if people get specific treatment, the specific treatment is superior to an unspecific treatment so far. And so the number needed to treat is around 10 in the last meta-analysis. And this is also from Mark's publication. And if we look at the number needed to treat for antipsychotics and psychological interventions, it's almost equal. It's 7 and 9 was it in that one. So if there are more studies coming in, the NNT goes a little bit down. But overall, it's more or less equal as regards the effect on prevention of psychosis. So that was the starting point for our study. Sorry. So the guidelines are saying that CBT should be used first, and only in certain cases antipsychotics should be used. Okay, so there was one similar study doing similar stuff before that. That was actually the last study from PACE, or the one before the one Pat will present on. So they compared cognitive therapy and risperidone, cognitive therapy and placebo, and supportive therapy and placebo. And they found that actually adding risperidone to the cognitive therapy group didn't make much difference as compared to the supportive therapy group. Overall, there was no significant difference between the three arms, but if you would collapse the cognitive therapy two groups, then I think there was a statistical tendency for the cognitive therapy group to be superior to the supportive therapy group. So we came up with a similar design, but still slightly different. I don't know what I have to do here, actually. There were no differences as regards the symptoms or functioning outcomes. So this was our design because we thought that what was regularly happened. So people would get an antipsychotic and some clinical management. So we were comparing these two kind of active conditions compared with placebo and clinical management. What happened in practice is that actually all arms got much more attention than they would get in usual care. That's some of the problems of those trials, that overall people end up with much more attention and support than they would end up in non-research settings. Okay, so these were the research questions. So clinical management and aripiprazole combined are more effective than clinical management and placebo combined, and CBT not more effective than clinical management, but not less effective than clinical management and aripiprazole. So we had 10 centers around Germany who did that trial. These were the inclusion criteria. They were slightly different from the ones you have heard before. So we added the basic symptom group to the ultra-risk group, which is COGDIS here. So there is a certain tradition, especially in Cologne, where I have been before, to look also for subtle cognitive and perceptual aberrations. And we had a kind of sub-staging model in the 1B stage. So we were saying that those who present with the basic symptoms could also progress within the 1B group to APS or BLIPS. So we had like a progression outcome. So there's not only a progression from APS or BLIPS to first episode, but there's also a progression from basic symptoms to APS or BLIPS, right? So the primary outcome was to prevent the progression to a, say, more severe stage, right? Okay, so it was relatively well designed, so blind ratings as regards the CBT condition and double blind as regards the pill conditions. So there's also a manual, and we also measured adherence and so on. But you have to study German first before you can read this manual, unfortunately. Oh, it's really, I don't know what I have to do with this thing here. It's very slow. Okay, so there was pilot data. It was actually very, very kind from Scott Woods, because he provided us with his data when the study wasn't published yet, and that was one of the reasons why we could actually get funded, because we obviously there were safety issues in that group. Okay, so this was a statistical analysis. So we tested first for equal progression in all three arms, and then we did pairwise comparisons between the three arms, right? So we used a full analysis set for the analysis, so people had to be randomized, and then they had to have one assessment and at least one CBT or pill intake. These was the consort chart. So we screened quite a lot of people, 3,000. What was interesting is here that out of the ones who were actually assessed, this is the 800 here, there were more than almost 200 who already got antipsychotic treatment and had to be excluded from the study because of that. So it's exactly what I said before, that in the field actually many people get treated with antipsychotics in the at-risk mental state. Okay, so it's still not working. So at the end there were 280 randomized, and the full analysis set was done for then again a little bit smaller numbers than those who were randomized. This is the baseline characteristics. So this was all done in adult psychiatry. So the at-risk population was relatively old. So they were 24 of age. So very different to Helen's populations actually. And most of the intake criteria were, or most people fulfilled the attenuated psychosis intake criteria, followed by the basic symptom criteria. So as in most trials, you would have mainly the majority of clients would fulfill the APS group. Okay, maybe drop that. The duration of the program was relatively long, and referrals were mainly made from people who were already treated by psychotherapists or psychiatrists. So we were relatively, it took a time actually until people got referred. So we were not really low threshold, which had to do with the fact that the study was done at university hospitals actually, and it were kind of specialized outpatient departments, but it was still a threshold actually to be treated there. So these were the number of sessions. So the treatment was offered over 1 year. So people got actually quite a few CBT sessions, so 21 on median, and they got less sessions in the pill and ARI condition. This is the main result. So the primary outcome progression to psychosis. So the green line is the CBT group, so they did best. The blue line is the ARI group. And I think the clinical difference is really meaningful. So it's almost 10% here compared to placebo. But if we compare the 3 arms, there's no significant difference. Only if we do pairwise comparison, we have a tendency actually for the CBT condition to be superior to placebo. Although I would think that this is clinically meaningful, right? Okay, so this is transition to psychosis. Again, the green line is the CBT line. And surprisingly, the placebo did better actually than the aripiprazole group. So they actually end up with the same transition rate, more or less. And there was no significant difference when you look at all 3 groups, but there was a tendency, oh my God, it's really annoying with this. And there was a tendency for the CBT group to do better than the placebo, the ARI group actually, which is a bit surprising, obviously. So as regard continuous measures, there were no differences, or it's probably hard to see for you. So both groups, or all 3 groups improved, and there were no significant differences at the end, right? So all 3 groups did better as regards the attenuated psychotic symptoms, the basic symptoms, functioning, and also depression. What was interesting was, and that's also part of the reason why the ARI and placebo group got much less sessions, was that actually the dropout was highly significant different, right? So this is again the CBT condition. So people stayed much longer in the CBT condition than in the ARI and placebo condition. And this was significant, right? Okay, so to sum up the results, so we showed that progression to psychosis could be relevantly reduced with CBT compared to placebo. Also, a clinically relevant reduction of transition to psychosis could be achieved, also in favor of CBT, but in comparison to ARI only. There were no differences in symptoms and functioning at the end of treatment between the trial condition, and there was a significant higher dropout rate for the ARI and placebo condition than for the CBT condition. So overall, the supports the recent recommendation of the guidelines, which say that you should start with CBT first, or maybe even with a more benign treatment, like Helen presented. And antipsychotics should only be used second line, if at all. An issue is, as I said before, that actually all trial conditions got relatively more support than they would get in routine care. and maybe still, or I would say, or would support what David Fowler also presented this morning. I think we should focus more actually on real life outcomes rather than transitions like improving functioning and so on. That might be a way to go with future studies, maybe to involve individual placement and support and so on, since functioning actually didn't improve in the specific conditions. So it improved overall, but the specific conditions were not superior to the non-specific condition as regards functioning. Okay, and I would like to thank all the centers and the many, many people who have been involved in this study over the years. Thank you very much.
Questions? What's the dosage schedule with now?
Yeah, good question, of course. It was 2 to 15 milligrams. Yeah.
Relation with dropouts with dose?
Yeah, we weren't able to look at that yet. It would be interesting to look, obviously, yeah. But what was interesting that the dropout rate was actually in the placebo group was even higher than in the RE group, right? Yeah.
Can I just jump in and ask a question? The age that you mentioned, 24 and 16, what impact do you think that has on risk for transition?
Well, they had a long duration of prodrome in that group, and overall, the transition rates were relatively high. So I would assume they might have a higher risk when being older, right? And probably since it was not a really low threshold or non-stigmatized and so on, the centers, the threshold to get this kind of help was relatively high. So people were probably relatively symptomatic or had a longer struggle through the health system until they reached the research setting. Yeah.
Just one question, maybe I missed something. Sorry, maybe I missed something. The dropouts from the aripiprazole treatment, were they early dropouts or they occurred later?
The majority was early, but it was on this one survival.
I missed something.
But it occurred. It occurred more often early, but it occurred also over time.
Okay.
Yeah. The whole study was 1 year, which is also very hard for young people to do, to stay 1 year in a clinical trial. So the overall dropout was high, obviously. Yeah. Okay, then I introduce you, right? So everyone knows Pat McGorry. Yeah, so we are excited to hear the results of the fish oil study, actually. Thank you.
Thanks, Andreas. Yeah. Okay. Well, these results have been presented already at the SIRS meeting, so I'll just present them again, but with some other comments as well, and maybe a little bit of the future thinking as well. And just would like to acknowledge all the huge effort that went into this study over probably took at least 12 years since Alison and I and others sort of sat down, I think, early 2000s to try to plan this study in Geneva. And took a long time to get the money, a long time to do the study, and a huge number of people, some of whom are in the room, contributed a huge amount to it. So I'd just like to acknowledge that at the start. Okay, so let's see now. I'm going to start swearing at this thing too. So I'll just skip over these because this is the background stuff, So these are some of the concepts people have been talking about of what this type of research is actually based upon, but also showing us how to do research in this more sophisticated way in these stages of illness. So I won't go into that, but and you've seen all that already. Sorry, it's just one thing, maybe this slide, I just mention this. This has been a controversial field, even the idea of being allowed to treat these patients who are clearly severely or significantly impaired, but they've been misrepresented, I think, in the press and lots of other areas. They really have got moderately severe impairments in functioning by the time they actually enter these trials. And we just contrast the number needed to treat on the right there with treatment of asymptomatic patients and the rest of healthcare. So we are doing pretty well here. And as Mark very clearly said, I think we should get Mark to talk to the politicians because he made it very, very clear. Just chopping off heads, that's what we're doing here. Okay, so this was the Neuro Pro Study, and it was conducted in a number of centres around the world. It was a major undertaking. We didn't have enough money to do it. It was funded by the Stanley Foundation, and we had to supplement that funding with program grant funding from Australian grants and other sources. So it was a great effort by everybody concerned. So these are some of the PIs. It doesn't include everyone who's an author on the paper or did major contributions. For example, Monika Schlegelhofer is sitting in the audience, and she did all the work actually, so in Vienna. So we want to acknowledge a lot of other people apart from those people who just are the PIs in the different centres. And I want to pay tribute to Gregor Berger here because he was the one that really introduced this idea of looking at fish oil. We all thought he was crazy, when he first brought it up. He was the one that really popularised us in our world anyway, popularised the idea. He's back in Switzerland now. But he did a study in first episode psychosis before we did these studies, which showed a real signal. It shortened the time to response, and it lowered the dose of antipsychotics that you needed to use in the first episode patients. And that hasn't really been followed up on or replicated since. And then the study was done in Vienna, led by Paul Amminger and his team there with Stanley Foundation funding. And that had very positive results. That's not the results. And the reason, this is just some of the rationale for it: low side effects, safe treatment. So the objectives of this replication study, because the results of the first study were so positive and even extending out over several years, the difference in transition rates, we wanted to do a replication, and we were able to get Stanley to fund it. These were the objectives. They're pretty obvious. Primary outcome was transition as defined, but we did actually look at the secondary outcomes, including, the primary outcome was transition at 6 months, and obviously secondary dimensional outcomes. Interventions were omega-3 and cognitive behavioural case management, which I think has been described earlier in the conference by Shona Francie, and this is a sort of a thing that was developed in the PACE clinic and in first episode patients as well, but something more flexible than CBT. It allowed you to treat other needs that the patient has, relationship problems and other case management issues as well. So it's quite a good thing to be doing for all the patients, and I think Mark made the point these patients do get a lot of input, which unfortunately tends to sometimes undermine the testing of the hypotheses. So this is what it included, probably what I just said, but there were particular modules based on what the patient actually presenting with, and people were trained and supervised, and taping sessions were taped to actually ensure that there was fidelity to this during this study. Now, the concomitant medication that was allowed was antidepressants, and that was about it, really. Obviously, antipsychotics were not allowed, or mood stabilizers. And the antidepressant use, I'm not sure if it's in later slides, I'll just mention it now, was much higher. The rate of use of antidepressants in the replication study was much higher than it had been in the original study, which is something we're looking at as a variable. Yeah, so I said that. So this is the assessment schedule, very, very intensive and time-consuming. Lots of different measures. The usual things you'd expect: diagnostic, assessments of prodromal symptoms, CARMs, and so on, but also other dimensions of psychopathology and functioning. So the first patient was recruited in 2010, and the last participant's last visit was in 2014. So it took 4.5 years, the study. And this is just showing the reasons for exclusion. I hope we've got sorry, I skipped over that. This is the slide that was commented on before. So there were nearly 1,000 patients screened, and about 304 were recruited. So it's about a third, I guess, isn't it, of the patients that were able to be. And I think it was probably similar to what was reported earlier. About roughly half went into each group. And the reasons for exclusion, you can see, the main reasons were already psychotic, which is actually, I think, as Alison's pointed out and Barnaby in other papers, this is a side benefit of actually doing this work, that you shorten the DUP and you get some first episode patients into treatment more easily. And other, I'm not sure what other is. Maybe it means that they didn't meet the criteria in the end. Just maybe number 6, past neuroleptic exposure. It wasn't a huge thing. I think in the US that would be a massive problem, and that's, you probably see in the Naples studies that probably about a third of the patients are on antipsychotics when they're in the Naples study, which is something that we try very hard to prevent in Australia. We've tried to educate our local GPs not to use antipsychotics in these patients. I won't go through all them. They're probably obvious. Past history of psychosis is an obvious exclusion. Abnormal coagulation profile, because fish oil can affect that. So if we know that the person's at risk in that way, we would exclude them. Yeah. Okay, so the characteristics of the sample. Interestingly, even though 2 to 1 in first episode psychosis samples, there's 2 to 1 male-female in this age group, we had a slight female excess, which I would say lowers the risk of the sample, probably. And mainly 80% Caucasian with a spread of other ethnic backgrounds. This is the highest level of education at baseline, so some of the were still at secondary school. And so it's spanning an age range of, I think, 14 to 40, I think, from memory, was the range in the study. Mean of 19, so we're halfway between Helen's study and Andreas' study. What was your mean age, Mark? Can you remember?
At baseline, I think it was 23 or 24.
Okay, similar to Andreas, yep, okay. Baseline measures, reasonably high level total BPRS, negative symptoms 18, that's significant, and so on. SOFAS 53, that's moderately severely impaired, if you look at the definitions. So, and the baseline SCID1 diagnosis, as you can see, quite a spread of other diagnoses, and no diagnosis in 25%. That's probably the thing to remember. So 75% of them will meet diagnostic criteria for other DSM disorders. So we definitely know they have a need for care as a group. Okay. So this is the bottom line. Unfortunately, no significant difference between the two groups at 6 months and indeed at 12 months. This is a survival curve, but transition rates, I'm not sure if I've got a slide of that. Yep. Transition rates at 6 months were only 5 or 6%, so much lower than what we had seen in previous trials and lower than in the first Vienna study. And at 12 months, only 11%, and obviously no difference between the two groups. Yeah, I think so. The good news is that all the patients got better, or not all, but they, as a group, they improved very significantly during this treatment phase. So the treatment that they were receiving, or either that or the natural course, led to a recovery in very many of these patients. Yeah, so these are probably just further analyses. We did try to analyse it by adherence, because the adherence was not that good compared to the Vienna study. It was definitely only moderate, I would say. But we didn't really find any effect of adherence as assessed by self-report and pill counts and those sort of measures. But we are currently analysing, it's taken us a lot longer than we expected, we can actually check what the adherence was by looking at lipid profiles in the blood samples, and that's being done now. So we'll probably have a more accurate picture of adherence. There's also a possibility that people were taking off-label fish oil from the supermarket, which is something we can actually check for, which didn't happen in the original Vienna trial, but probably these days it's not uncommon for people to just take fish oil just randomly, so we're going to check for that too. That's Paul's last hope, I think. Okay, so the sessions is actually there's a little bit of variation in terms of the dose in different centres, but overall it was pretty good. The mean number of CBCM sessions was about 11, and that's in the 6-month period, so that's probably one every couple of weeks, isn't it? Is that about right? Yep. And yeah, sorry for this. This is a very fine print. So I'll just pick out a few things here. 12 months and at 6 months, the transition rate was lower than expected, with an overall transition of 10.5%. Given this low transition rate, we thought a 24-month follow-up was worthwhile, and that's actually been completed now. And I don't have the exact figures, but the sense is that there isn't much change. There is a slight increase in transition at 24 months, but it doesn't open up a differential between the two groups, which is interesting in itself, that the fact that whatever was done has led to perhaps a more sustained effect than we saw in previous studies. So I've mentioned the compliance issue, and we're looking at that. And we are going to be looking at one point we did actually look at grouping people who were non-compliant with the placebo group, but then we didn't report that in the paper because people felt that was statistically not valid to do. But it did actually suggest that it's worth looking at in a bit more detail with the biological data. So we're going to do it that way. Now, there's a bit of debate in the group about what these findings actually mean. I mean, when the paper was submitted, and it's actually in press, I can't really say which journal it's in because you're not allowed to do that until it actually has appeared, but it's in press in a pretty good journal, and it will appear soon. But the debate is, what do these findings mean? Does it mean that the usual uncertainty about whether we sampled a low-risk sample, a sample that weren't enriched sufficiently for transition? We've had trouble working out how you assess that. If you look at the phenotype of the patients at entry was just the same as in the studies in the past where there was a higher transition rate. So this doesn't look like they're a less severely ill group at the beginning, but there may be something else we're not measuring which indicates they've got a lower risk, so that's still a possibility. I think a strong possibility is that, as I think Andreas' study showed, when you provide good psychosocial care, it does lower the transition rate. And that's what a lot of the studies that the first generation studies did show, that if you provide good psychosocial care, you can lower the transition rate. Not all studies have shown that, I suppose, but that's what we think, that the transition rate, the psychosocial care we think was much better than the first study. And so that's definitely one thing that we think is worth at least proposing as an explanation. The higher rate of antidepressants. There is circumstantial evidence from Barbara Kornblatt's work and also Phil McGuire at Oasis and his group that antidepressants might reduce the risk of transition as well, and that the use of antidepressants was higher in this group, and it was probably higher in the group that had higher depressive symptoms, which we know is a risk factor for transition. So maybe, the antidepressants use was something that lowered the transition rate in both groups. We're looking at that. Analyses are being done now, and that will be presented at ICOSA next April. So if I've got a little bit more time, I'll just move on, and just in the last... Yep. So these are sort of general conclusions from this area of work, that the phenotype is very clear. There's a need for care. There's a substantial risk of transition in these patients, and also comorbid or incident syndromes and poor functional outcomes, as people have said. We can reduce the risk, But the optimal type and sequence of treatment is now the thing we've got to actually work on. What is the right sequence for patients to be offered treatment? So our next phase of research is based on this idea of adaptive interventions, which very much models what clinicians do. So if you try something simple and then the patient doesn't respond, you move on to something a bit more complex and intensive and so on. At some point, medication of various kinds comes into the mix. But we haven't done trials, at least not in this group of patients, to actually elaborate the sequence of care. So yeah, so it's the same sort of. So we've been funded now. We tried to put experimental treatments into this mix as well, but we were dissuaded from doing that and just decided to look at the things that already are available in routine care. And this was funded, and it's just started recruitment as a much bigger study, actually, done purely in Australia this time. We probably got so traumatised by trying to run studies across 8 or 9 different countries that we thought we'd stick to Australia for a change. And we do have US collaborators. And the primary aim is just to test the sequence. And it is very much based on the staging or stepwise sort of approach. So the first stage is very simple supportive interventions, probably similar to what was in Andreas's control group, but it's manualized. Then cognitive behavioral case management, and then antidepressants as the next thing, but this time in a more randomized sort of design. So this is what it looks like. So you could say that the initial phase, which all 500 patients that are going to be recruited will be exposed to, this is not randomized the first step, it's just offered to everybody. And if they don't respond within 4 to 6 weeks, then they become eligible for randomization into CBCM or continuing with the lower level psychosocial intervention. So as you can see, it tests whether an increase in intensity and specificity of the treatment adds to your response rate. And you can see that passage to the next phase does not depend on transition in this study. It depends on response, which is defined as a remission of symptoms or an improvement of functioning. There's an operational definition of what response actually means. So it's a bit more related to more dimensional or functional sort of outcomes. And then finally, if they haven't responded after 6 months, they get randomized to antidepressants and continuing CBCM. And then at that point, there's a fast fail option. If they're still not getting better and people are worried about them, because you imagine the clinicians are sitting with these patients for 6 to 9 months and they're still struggling, they can actually opt out during that phase and choose to add on fish oil as one option, or low-dose antipsychotics as another option if they choose. So that's the kind of treatments that are available in our world at the moment, and it will hopefully clarify the sequence of therapy. Now, we think that this will actually lead to a very good response in nearly all the patients that are involved, because there may be a small group that prove to be resistant or don't actually respond to these interventions, and they're obviously an important group to study further. But that's what we think, and it's a very kind of simple study in a way, but very close to clinical reality. So we're hoping that it's going to go well in terms of recruitment. So I think was that the last one. There was one more. Anyway, it's probably a good place to stop. So that's the next step for us. There are lots of other candidates that we can be looking at in these patients, both biological and improving the quality of the psychosocial interventions, but that's for the future. I'll stop there. Thanks. So probably maybe take one question and then hand over to Alison, who's going to do a be the discussant.
Thank you for all this information. You report lower and lower transition rates. Could it be you are working for so long in Australia with the Head Start project that there is a change in culture, that people are nicer to adolescents?
Yeah, that's a nice thought, isn't it? I don't know. I definitely think that the culture of care that you provide these therapies in makes a very big difference to the patient in terms of engagement. But I don't know. It's hard thing to test, isn't it? But yeah, thanks for bringing that. It's the tone. We were talking to Danielle Schlosser yesterday, who developed the Prime app. and the tone of the way you present those online interventions, and I think in real life too, is very, very important. A lot of psychiatric settings are very depressing and, you know, burnt out, and if you bring the patients into those settings, I definitely think it has an effect. But that's a more general comment rather than about this. Okay, so just invite Alison Jung, Professor Alison Jung from the University of Manchester, obviously a co-PI on this last study, but obviously a key pioneer in this field to be the discussant.
Thank you very much, Pat, for the introduction, and thanks, Andreas, for inviting me to be discussant. I only found out about this morning, but it's given me sufficient time to actually bring some pieces of paper to the event, which is better than I did yesterday when I was discussant and had to write everything on my hand. So thanks to all our presenters, very interesting information that we've been presented with, and I guess I'll just make a few points before I throw it open for discussion. So I think that everybody mentioned the number needed to treat, and Pat highlighted this in his presentation, which is, you know, we are criticised again and again, and we have to make the same arguments again and again, that it's justified to treat this group of people. For a start, they're help-seeking and they're symptomatic, so they are not well. They don't have a diagnosis of a psychotic disorder, but they're not well. And the number needed to treat is very low when you compare it with things like treating hypertension to prevent a cardiovascular event, or the breast cancer screening to pick up one case of breast cancer. So I think that really we are justified in continuing in this field, especially given a lot of the really positive findings that we've had. A second issue that was brought up was outcome measure. So I think Andreas brought this up about the problems of having a dichotomous outcome measure, as did Helen. So transition or no transition. And it is certainly becoming a problem as we see lower transition rates. But both Andreas and Mark brought up the issue of a trichotomous outcome measure. So I think with Mark, he was talking about no negative outcome, continued attenuated psychotic symptoms, or actual psychotic disorder. So that's a novel way of having still categories, but a trichotomous outcome measure. And Andreas had no negative outcome, but also looking at transition from early prodrome stage to late prodrome phase, and then actually development of psychotic disorder. So I guess we need to sort of think about what are the outcome measures. And of course, as Pat brought up at the end and others brought up in relation to functioning, do we need to also have that maybe as a primary outcome measure, some kind of a dimensional outcome? Some interesting issues about the sample. And I was discussant yesterday, unprepared as I was, looking at gender differences in schizophrenia and early psychosis, including in the at-risk group. And what was presented yesterday was all the samples had higher levels of males than females. Yet in our Neuro Pro study, and actually all the time in the PACE clinic, we've always had higher levels of females compared to males. So there's something about that sample. Pat suggested maybe they actually got a lower risk of transition. I speculated yesterday, for those of you who weren't there, that females have higher help-seeking behaviours. They're more likely to talk to friends. They have more social contacts. And is it maybe that they will seek help earlier and perhaps get help from things like youth headspace, youth mental health type services? So maybe they come in already with a lower risk of transition for a number of reasons. It was also interesting that you were all talking about the age range. So we had, Helen, you had the lowest mean age of about 16. Pat, we had 19, and the Mark and Andreas around about the sort of 24, 25. And the transition rates were actually higher in the older age group, which is interesting because the Naples group, is there anyone here from Naples? The Naples group have just recently published data about an algorithm to detect high transition rate, and they actually nominated lower age as being associated with higher risk of transition. So that's kind of at odds with what we're finding in these intervention studies. So I think that is something that we really need to keep an eye on, is certainly looking at age and gender as being important factors in the transition rates that we see. The other issue is control groups. And of course, we always have this problem in doing intervention studies where ethically we can't have no control group. We can't deliberately be mean to people to try to get them to develop psychosis. That's, those ethics committees have got a lot to answer for, don't they? So it is difficult to choose a control group that is acceptable, obviously, to patients, to carers, to ethics committees. And I think, you can see the point, because when it comes to the real world, people will be receiving a treatment, and we want to know if our kind of experimental treatment adds something on top of that. Of course, the problem is, in the real world, they never get as good routine treatment as you do in the control group of an intervention, and so I think that affects our findings as well. Another issue was the CBT, so not in relation to our Neuro Pro study so much, but what's the target of the CBT? So Helen, you talked about the CBT really looking at the non-specific symptoms, I guess the depression, the stress, the anxiety, whereas Mark, your model, which is really based on Paul French's model, and Toni Morrison's model, which is looking actually at the psychotic-like symptoms themselves. So the management of the safety behaviours, normalisation of the type symptoms, testing them, your horrible, tortuous sitting on the toilet in the dark type of treatment. So, the CBTs that we're seeing are not all the same. And I was very struck, actually. Pat had a quote from a patient in the plenary session yesterday about, trying to find the right treatment is like trying to find a shoe that fits. And if you're trying to make steps with a shoe that doesn't fit, you can't do it. So you need to find the right treatment. And one type of CBT might not be suitable, might need a different one. Some people obviously really responded to the non-directive reflective listening, and which really relates also to therapeutic alliance. And I said this yesterday as well, actually, but I've recently seen a presentation from Shone Lewis, who talked about the importance of therapeutic alliance in response to treatment. And they did an interesting sort of secondary analysis where if the therapeutic alliance was good, then the treatment was effective. But if the therapeutic alliance was poor, not only was the treatment not effective, it actually made people worse. So I think it's important that we do measure therapeutic alliance also when we're looking at treatments. Another thing that was mentioned was concomitant treatment. So do we exclude people who are on antidepressants because that might reduce the transition rate? But then you have the problem of having a very selective group, and that's possibly not generalisable to your population as a whole. So that's a tricky one in terms of how do we choose our sample again. Sequential treatment, I think, was mentioned by most of the presenters. So do we now go from a very non-specific, acceptable, kindness, genuine listening type of psychosocial treatment, then to maybe CBT? What type of CBT? I think we actually need to think about that. And then to more active, maybe more toxic treatments as well. And finally, I guess the issue is the biomarkers. And do we need to have hypothesis-driven research that says, okay, if somebody's got high inflammatory biomarkers, do we try anti-inflammatory medication? If they've got disorders of fatty acid membrane or something that makes us think they will respond to fish oil, maybe vitamin D. So do we need to be a bit more sort of hypothesis-driven about where we're going, moving to personalised medicine? And just to finally mention another trial that's currently going on. So there's several trials still going. The fish oil bandwagon is not finished yet. So there's a multi-site fish oil trial that's currently being funded. So there's one in the United States, and there's actually a new one just started in Europe. Are you involved in that, Andreas? Yeah. Mark, are you guys involved in that one? Yeah. So fish oil is still being looked at, and we've recently also got funding to look at minocycline versus fish oil in a 2x2 design that's going to take place in Pakistan. So there's still a lot of exciting trials going on, and I think that it really is an area that we should still keep looking at. So that's enough from me. I'll throw the floor open to questions, and I don't know, is it me now, or do you two come up? Oh, it's me, okay. So is there any questions for any of our speakers or me?
Thank you for that, Alison. I was just wondering, you did this, I think I saw you did the SCID too on the Neuro Pro Study. Was there any difference in the transition rate if you were to take out people who scored for BPD, borderline personality disorder?
Pat, do you want to comment on that? Was there any difference in the transition rate if we excluded people with borderline personality disorder? Before you answer that, I will actually refer to a previous study that we did, which looked at transition rate in people with borderline personality disorder or no borderline personality disorder, and there was no difference. But I don't know about specific Neuro Pro.
I think Paul Aminger has looked at this in the Vienna sample. Is that right, Monica? Yeah, with Andrew Channon, and I can't remember what he actually found, unfortunately, but we could go back and have a look. It was a bigger sample there, so maybe we could actually have a more specific look. But I'm pretty sure that Andrew and Paul have looked at this in the original Vienna study and written a paper about it. So
can everyone hear Pat?
did you hear?
Yeah. Okay, so Richard and then someone at the back.
Just two quick points. What about categorising by subphenotypes by comorbidity? And also there's a family therapy study, isn't there?
Yes, there is. So Richard asked, what about categorising by comorbidities? Yep, good question. We can actually probably do a secondary analysis. Be good to do a secondary analysis of all of the studies looking at that. Yes, sorry, I should have mentioned there is a family therapy study which is being done in the United States on the Naples group, and they've actually released some preliminary data which showed that family therapy, which was directed towards reducing sort of stress in the family, so it was quite a specific intervention around family functioning, and they found a reduction in symptoms and distress. They haven't looked at the transition rate yet. So at the back, and then Kirsten.
Yeah, thank you. A great symposium. I was wondering, but I think you already mentioned it, that in the Neuro Pro study, if you're going to look at inflammation or fatty acid metabolism, whether that stratifies the risk of getting a transition when you're on fish oil or not, because I think that would be very important.
Yeah, so we have looked at that, and what is happening with that analysis, Pat?
Well, it hasn't been analysed yet, but we are collaborating with Professor Bernard Bauner in Adelaide, who is looking at the inflammatory biomarkers and oxidative stress, and the lipid analysis.
We did the fatty acid thing too, didn't we?
That's being done in Wollongong, believe it or not. It's a place in New South Wales, and it's been a bit slow, so. But it is being done, and it's being done in a predictive way, as you say, to try to see what Alison was saying at the end. You know, is there other subgroups? It could be that the subgroup might be more responsive, and then you'd have to do another study with that subgroup. You know, a prospective study again. But we're definitely going to look at all that. We've got blood and biomarker data, but it's just. You can imagine the shipping of this stuff around the world. That's one of the reasons why we're just doing it in Australia this time.
Very interesting work. And my question is probably to the thinking in the sequential treatment design, whether there's any consideration of the heterogeneity of risk within clinical high risk or arms groups, because I think of how many transitions are within 6 months, and so people may not get who really need higher intensity treatments soon enough, and if there's any consideration of using a personalized approach based on the degree of risk within the group.
Yeah, thanks. That's a really interesting question. Do you want to answer it, or will I say something? So I think that's what we really need to do, so stratifying the at-risk group, because there are some people who make early transitions, and the Naples group have found that there's some young people who make transitions. So, there's something going on with them that they're at very high risk. Whereas, so we really need to identify those people, because otherwise we're messing around for too long with ineffective treatments. Where there are other people who, we should give them the benefit of the doubt and try a psychosocial treatment, and that they might get better. So I think that that's definitely the way forward as well. We need to just get a bit smarter about what we're doing. And how are we going with the time? Last question.
My question is for Professor Strain. I've been interested by the findings about the outcome of non-directive reflexive listening. I'm wondering whether did you find any difference between people responding to CBT and people responding to non-reflective listening? Because I think that in the future even the issue of psychotherapies could be put within the framework of a personalized medicine.
We didn't find any differences in terms of like their clinical presentations. If we looked at the baseline data, there was no difference between who went into the CBT or the other group, their functioning at baseline or anything like that. And I think also, we have to treat it with some caution, because as I said, the study was really underpowered. We had a small sample size. But I think it's food for thought to think about, are there, when we get to the younger age group, should we be looking at different variations of treatment at earlier stages? And as Alison mentioned, perhaps different types of CBT. Oh, we're on the countdown. Yeah, right, we've just been red carded. So thank you very much to our 4 speakers for really interesting talks. Thanks for the audience for your participation, and we'll end it there.